I'm proud to introduce Professor David Armstrong. For those who are unfamiliar with David Armstrong, I would like to remind you that he signed almost 600 publications as first author in indexed journals and 1,000 as a co-author, collecting over 14,000 citations. In my opinion, these are underestimated values. Many of the evidences that are part of our Italian and international guidelines are the result of his work, and his opinions are those most popular. Today, we will listen to a lecture from Professor Armstrong on diabetic foot ulcers and COVID-19 and post-COVID-19 complications. I would like to publicly thank David for the generosity with which he gives himself and the modesty that marks only great clinicians. Thanks, David.
Oh my gosh, Gaetano, thank you so much. What a kind introduction. After a kind introduction like that, you can only be disappointed. But it's such a pleasure to be with you, even transatlantically, but still feels like family. And I hope you can see my slides okay. And if you can, I'll begin. And again, Gaetano, my best to you and the rest of the organizers of this wonderful symposium. And whether we're talking from Los Angeles or Napoli or anywhere in between, maybe the next time it will be together, not separated by this terrible pandemic. But let's get started, because I was asked a little bit to talk about building teams with in the hardest and the toughest of times. Just yesterday, last night, I was lecturing to Malaysia, to Kuala Lumpur, and I was speaking just on building teams in general. But because of how much I think Italy in general was impacted, I think, and our own country here in the United States and Los Angeles was impacted, I think maybe time for a little perspective on this. And I'll start with this book. At the time of the last pandemic, or the beginning of the pandemic, it was actually in January, I was actually reading Gabriel Garcia Marquez, completely coincidentally to all of this. And look how apropos it is now. But what we're going to be talking about is maybe a limb, not love in the time of cholera, but limbs in the time of COVID. And we're going to talk about a little bit about humility, rather than hubris, in limb preservation and ways forward to sort of move forward. And by the way, I know Gaetano knows this, but we give all of our slides away. If you want any of them, I'll make sure to post them right after all of this, but you can also email me or tweet at me or go to our website. We just ask you to copy the slides, make them better, and pay it forward. How does that sound? So let's begin. Really, what we're going to discuss in the big scheme of things starts with the most humble of things, and it's the foot. This is what I do for a living. I'm a foot doctor, a toe mechanic, if you will. And, I can think of two great gifts that are given to someone who gets a chance to work out there in the periphery. And the first one is maybe not initially obvious, but I can't think of anything in this era of hubris and overconfidence. I can't think of anything that's more of an expression of humility than looking after someone's feet. It crosses all borders, all religions, ethnicities, even time, really. And looking after the feet has always been an expression of humility. But one of the other great gifts, in addition to that, is that working on the end of this anatomic peninsula, surgically and medically, it gives someone this great gift of perspective, and it gives you this great opportunity to collaborate with the anatomic mainland. Unfortunately, right now, the perspective is difficult, especially during the time of COVID. But I'm not going to talk initially about 2020 or 2021, but I'm going to talk about another annus horribilis, and it was 2009, and everyone seems to have forgotten about this because this was the last sort of global sort of economic catastrophe, but it was also probably the most important year in our lives collectively. And what do I mean by that? Well, let me show you this. In terms of public health, this was probably even more important than this year in the big scheme of things, because that year was the first year in the history of humanity, 2009, that more people died of non-communicable diseases, of NCDs, diabetes, heart disease, cancer, than from all of the plagues in the world combined. That was the first year in the history of our species. And that same year, HIV/AIDS was passed by diabetes in terms of its role in world mortality and so-called excess deaths. So you see that year showed us now that, you know, we instead of dying from disease as we have throughout humanity of these communicable diseases, we started dying of decay, if you will. It's these diseases of decay that are the bane of our existence. And it starts to get you thinking about this. If you add up these communicable diseases that we have known throughout our species lifetime, and then if you add up these newer diseases of decay, like heart disease, cancer, diabetes, then adding them up in the face of COVID really equals death. And you see these early data from from MMWR where people with these non-communicable diseases like diabetes especially were at over 10 times more likely to be hospitalized and die than were people without those. So this equation says that we really have to start thinking about how we look after these patients. And then within that disease, the other big picture is that you have this other sort of largely ignored condition at the end of the body, this humble, small condition that is looking after the foot in diabetes. But unfortunately, foot complications in diabetes are common, they're complicated, and they're costly. And what do I mean by that? Well, if you look at these data from last year that we just published, you see that if we look at World Health Organization data in terms of years lived with disease, these demography is catching up with us and has almost enveloped us, because in every part of the world, in absolutely every age group, these complications associated with the lower extremity and diabetes are increasing over this last generation, and they are all continuing to increase. And now there is a diabetic foot wound every 1.2 seconds around the world. About half of these patients get infected, and that's why there's an amputation every 20 seconds. And then once that happens, look at these data. We can compare. It's not fair to compare one terrible thing to another, but let's compare foot complications to cancer. These are also very recent data, repeated after a study we did back in the late 2000s. But you see here that things like diabetic foot ulcers by themselves afford our patients a 30% 5-year mortality, comparable to all cancers if you were to add it up. But then if you look at minor amputation added onto that, we're talking about 42 to 45%. Critical, or I should say chronic limb-threatening ischemia, we're now well over half, pushing 60%, and then high-level amputations anywhere to 60 to 80. These are at least as bad as a bad form of cancer. And, you know, we would never think as a family of withholding therapy from someone with breast cancer or lung cancer or skin cancer or whatever, unless the patient asked for it. But this kind of nihilism, pessimism happens all the time with people with wounds, because we say, oh, this patient, she just has this wound, she's going to get another one. Why don't you cut the leg off and be done with it? And for most patients, I think most of the data are pretty clear that that's probably not the best thing to do. And so I think as a family, we can make a difference, not only in Italy, not only in the United States, but really worldwide. But if we're doing it during a pandemic, I think There's a saying in English, we say all hands on deck if you're trying to accomplish something. Well, for what we're dealing with, this common, complicated, costly condition, maybe we can say all feet on deck. And at the height of the pandemic, I think in March of last year, we came together and issued a special communication where we tried to help to classify these complications, to help triage patients that we were dealing with. And I know I was communicating very often with colleagues in Italy who were doing some of the most serious thinking on this subject. But the great thing is that we found that we can do a lot of things at home. Probably more than 95% of this care in an emergency can be done at home. Even some of the things that we thought could never be done there. And we're going to describe it. So we had a classification 1 through 4. But if we look at the lower categories, things stable conditions with just an uncomplicated wounds, those things can be done by telemedicine fairly easily. Guarded conditions are people that have an inactive Charcot or an improving wound that can also be done at home, maybe in a clinician's office. But then only, if you look here, maybe 1% of our patients in the big scheme of things as a population will have serious or critical conditions. And these may be able to be done, not even in a hospital, but sometimes just in a clinic or in an outpatient facility in a significant emergency without putting that patient or the public health system at significant burden. This really, I think, took off and helped to triage patients in the United States. But it's really, let's just look at one simple example. This is a very complicated patient, but the concept is simple. This is a man who had an ejection fraction at the time of 15%. He had a diabetic foot infection coupled with severe ischemia. I did a guillotine amputation here, as you see here. This was in February before the pandemic. Late February, my partner, Vince Rowe, did a bypass, a very exotic bypass at the time. And we were thinking of seeing the patient, but then the pandemic hit in March and everything was closed down. And we're thinking, as we see this wound deteriorate now, you see almost half has necrotic tissue on it. How are we going? This patient needs to be debrided. And so we're thinking maybe we can go to the patient's house and debride it, or maybe we can have them at a third site. But then we thought, well, why don't we enlist maybe the support of our little friends? And I'll show you an example of this. So we were treating the patient by WhatsApp. We think this was the first example of this happening. And we had some of our team members who are nurses who are awesome, and we trained them to put on maggots, larvae. And I'll show you this. You'll see these larvae now, the larval application down here, but this is day 0. You see here on the first dressing change. 2 days later, this has gone from 45% necrotic tissue to just about 20 or 30%. Then we applied the maggots again. The patient was offloaded and protected. All of this happening at home with the whole family there taking pictures, everyone WhatsApping everyone else. You see this all happening. This is the second dressing change, now down to 14%. And then you see here the third dressing change. This is after just 1 week. And then we kept on doing this weekly for the next couple of weeks until things calm down and we can get the patient optimized, get the ejection fraction up just a little bit, get him into the operating room. And then I debrided his wound. You see this happening up in the upper left. And then the wound sufficiently debrided preoperatively. And after my debridement, my partner, Keaton Patel, who's a gifted plastic and reconstructive surgeon, put a superficial circumflex iliac pedicle, or skip flap, this beautiful little thin, low metabolic demand free flap on there. And there we are. So this was done only with 1 day of care in the hospital and about 21 days of care at home, even at the height of the pandemic. And this is a relatively complicated patient, but there was nothing very fancy about this except for WhatsApp. And we use the most low-tech surgeons, our maggots. And things like this, pushing care into the home, could have a very positive effect. You see a study we published in the middle of the pandemic in diabetes care here, led by Laura Shin and Frank Bowling. And we compared a tale of two cities, Manchester, our sister unit, and Los Angeles. And you see the clinic visits pre and post lockdown, very similar pre-pandemic. But during the pandemic, a lot more telecare for both units. And then you see in England, they were able to have a lot of home visits by nurses. What we did was we had a lot of home visits with family members there. And you see here, pre and post lockdown, the hospitalizations dropped significantly amongst our pre-existing patient population. So that was kind of in the first big wave of COVID. But then what happened in the second wave? Well, in the second wave in Los Angeles County, I think things got a lot worse because many of the patients that we were caring for, we managed to keep sort of in the family and at relatively low risk. And the high to low amputation ratio was only 20%. However, in the second wave, where we started to get a lot of patients who were coming in from outside of our system into our system, who were waiting, understandably waiting for care at other facilities that maybe didn't have access to this team care. Many of them entered our system and were so infected and or ischemic that they required high-level amputation. So you see in December to January of this year, just a terrible rise in that high to low amputation ratio within our population that we cover within Los Angeles and Los Angeles County across a 10 million person population. So that is what we reported. That second wave was even worse than the first for those reasons, we believe. But, you know, if you start thinking about what we can take from this, maybe if we're moving from maybe all feet on deck, maybe we can talk about taking some of this technology and extending it out into the post-pandemic period into what we might call a wound center or a tissue loss center without walls. And we published this last year as well. It was a group of folks led by Lee Rogers, my former fellow. And we talked about maybe methods of triaging patients with tissue loss in general. And you see this very similar to what we published just for diabetic foot complications. But in addition to that, we really talked about a pre and a post-pandemic model of care. And sort of the pre-pandemic model of care might be predominantly hospital-based with very little care being done at home. But the peri and post-pandemic model of care really would be to maximize the site of service, meaning maximize the care in the operating room, in the surgery center, in a clinic, but even at home, like we showed in the last case, that simple case of that last patient. But also, we think that some of this stuff is here to stay. And so much more of our care that we're doing is done at home or even by taking photographs of patients and sending them in. Even though we did that a lot pre-pandemic, now it's just part of our everyday existence. And I'll tell you what's exciting now is that the big picture suggests that maybe this was an annus horribilis, but I think at the end of the day, there's a lot of hope. And ladies and gentlemen, I'm going to conclude with this. I told you that at the very beginning of the pandemic in 2020, I happened to coincidentally be reading Gabriel Garcia Marquez. And, you know, as I was reading it and as I was reading him in this book, I had found that I had marked one page that seemed to summarize the whole thing. And Don Gabriel said that the heart's memory eliminates the bad and magnifies the good. And thanks to this artifice, we managed to endure the burden of the past. And you know, I was thinking about this quite a lot, even as we were right in the middle of all of that bad. And I was thinking to myself, even in the middle of all that bad, there was a lot of good going on. And I don't think that's artifice. I disagree with Gabriel Garcia Marquez. I think that there is a lot of good that's coming out of this. And I think we're coming out of this not only a better specialty in this area, but really a better world. And I think where we can look after these patients even better and help our patients move through the world a little bit better each and every day. And that no matter what their health, no matter what their age, and no matter what virus happens to be floating around. So, Mr. Chair, ladies and gentlemen, I'm honored to participate in this. Thank you so much.
Thank you very much, Devin.